evening, everybody. A very warm welcome on this rainy monsoon evening in Bombay. Today, we're going to be speaking on a topic which is so important and yet date. Bronchiectasis and what's new in bronchiectasis in 2026. Very often we have patients come to us. Very often we have patients who come to us have been on inhalers, have been diagnosed as asthma, have been on oral tablets, but the current clear diagnosis of bronchiectasis is never made. And most often, the lungs are destroyed by the time the patients come to us. And very often, the first presentation to a pulmonologist is only in the form and a setting of an exacerbation. With that note, we're going to have a dynamic webinar on bronchiectasis. We've got a fantastic speaker and wonderful panelists who are going to help and enlighten this talk for us. Before we start today's webinar, I'd like to profusely thank the Indian Chess Society and Dr. Amita Nene Madam, who's the Secretary of ICS, for spearheading and wholeheartedly guiding the obstructive airway disease webinar series and ensuring that the academic activities reach every part of the country. I'd also like to thank Rakesh Chawla, sir, who's the President of ICS, and Radha Munji Madam, the Treasurer of ICS. We've got a colleague from Delhi who needs no introduction, Dr. Saurabh Mittal, a prolific speaker. Can we have Dr. Saurabh Mittal CV up? Yes. Dr. Saurabh Mittal is MD Medicine, DM Pulmonary Medicine, multiple fellowships to his name, currently working as an assistant professor in the Department of Pulmonary Critical Care and Sleep Medicine at the prestigious All India Institute of Medical Sciences, New Delhi. A keen interest in sleep medicine, tuberculosis, pulmonary physiology, and interventional pulmonology, and has over 200 publications. A fantastic speaker and an academician, and I'm sure he's going to teach us the nitty-gritties of managing bronchiectasis, and I'm eagerly waiting to listen and learn from him. So without wasting further time, I hand over the session to Dr. Saurabh Mittal.
Hi, good evening, everyone. So in next 20 minutes, we'll talk about the diagnostic evaluation of bronchiectasis. And I'll be only talking primarily on the diagnostic evaluation, and therapeutics will be discussed during the panel discussion. Okay, so bronchiectasis is something which is not a new disease. It has been there for a very, very long time, but we all have managed it and somehow we have mismanaged it also. So what I'm going to discuss in next 20 minutes is that what actually bronchiectasis is, how do we diagnose that the patient has bronchiectasis, what are the features, how do we investigate the etiology of the bronchiectasis, and then how do we assess the severity of disease. And management and treatment part would be discussed in the panel discussion. So what bronchiectasis is, we all know. What I want to emphasize is that bronchiectasis is both a clinical disease as well as a radiological appearance. So these two are different. So radiologically, there is something called bronchiectasis, and clinically, there is something called as bronchiectasis. So bronchiectasis word comes from bronchos and ectasia, that is bronchial dilatation. It is irreversible dilatation of the cartilage containing the airways. If you see, there is irreversible damage to the bronchial wall, which leads to mucosal thickening and mucus impaction, which leads to the problems in bronchiectasis. This is pathological definition of bronchiectasis, or we call it radiological definitions because we see it on a CT scan only. But there's something called as the clinical definition of bronchiectasis. So bronchiectasis is a chronic respiratory disease which has symptoms of productive cough and recurrent respiratory infections due to permanent dilatation of the bronchi. And what are these three things should be there? So out of these three, there should be at least two to call it a clinically significant bronchiectasis. That means patient has cough on most of the days of the week. Patient has sputum production most days of the week, and there is history of exacerbations. So a presence of permanent dilatation of bronchi on radiology, when it is associated with these symptoms, it is called as clinical bronchiectasis. Now, next, why does bronchiectasis occur? So bronchiectasis occur in a patient who is genetically predisposed and they have certain host factors like immune deficiency or altered airway anatomy because of some tumor, some foreign body. If there is impaired mucociliary clearance, it leads to multiple infections, various environmental factors. All these contribute to the development of bronchiectasis and then lead to perpetuation and worsening of bronchiectasis because of the continued inflammation and continued cycle of infection and bronchial damage. So what do we call radiological as bronchiectasis? So classically, the Hensel's criteria have been told to diagnose bronchiectasis on a CT scan, which says that a bronchial diameter larger than the accompanying pulmonary artery. So we'll see CT scans once you have a larger bronchial diameter than a pulmonary artery, it's called as bronchiectasis on CT scan. The other features include lack of normal bronchial tapering, as well as if you can see the airways till the pleural surface. Now, this definition has been there for a long time, but the problem with this definition is that it cannot be applied to patients who have cardiovascular disease, because patients with cardiovascular disease will have a pulmonary arterial dilatation also. So in that case, even if bronchial diameter is increased, it may not go over the pulmonary artery diameter, and this definition may not apply in elderly also, because some elderly individuals may have a high ratio without having any symptoms of bronchiectasis. So this definition has been there and remains a gold standard, but it has its own problems. So now we'll see what are the types of bronchiectasis and how do we diagnose bronchiectasis. So classically, there have been three radiological types of bronchiectasis, that is cylindrical, varicose, and cystic. Cylindrical means you see that the bronchi which used to be tapering have become cylinder-like. Varicose has multiple varicosities in the airway wall, and cystic becomes a cystic spaces. So this is a morphological classification of bronchiectasis. So when we talk about bronchiectasis, there are certain things which can be seen on an X-ray, and there are certain things which can be seen on a CT scan. So when we talk about an X-ray signs of bronchiectasis, in most patients, X-ray might be normal. There are certain specific findings of bronchial dilatation on X-ray, which would include a tram track shadow or sometimes a signature shadow, not very commonly seen. There are certain non-specific signs which we will see. There is peribronchial coughing, finger in glove, or multiple air fluid levels. Okay, so in these two X-rays, if you see the first one, you see there are a lot of multiple cystic shadows. So this is a cystic bronchiectasis, which is easy to identify on a X-ray. Sometimes you can see the fluid levels also. If you the second X-ray, sometimes you may take that it is a normal X-ray. Okay, but if you look carefully in the second X-ray on the right lower zone and right upper zone also, you can see there is a tram track appearance, because you see there are dilated bronchi which are non-tapering, and you see those shadows in the lower lobes as well as in the upper lobe. So I'm pointing towards various areas where you can see bronchiectasis. So a novice reader may actually take it as a normal X-ray, but there is bronchiectasis on this X-ray. So it is important to identify bronchiectasis on radiograph also. So this is a very classical X-ray of cystic bronchiectasis with multiple air fluid levels, because there are a lot of air fluid levels and secondary infections in the bronchiectasis. Another finding on X-ray can be mucoid impaction, which can be seen as finger in glove appearance. So you see these right upper lobe shadows, there are secular opacities, which tells you that these bronchi are filled with mucus and they are secularly dilated. That's called as the mucoid impaction. So these are certain features which can be seen on a chest X-ray in a patient with bronchiectasis. Now we talk about the CT scan of bronchiectasis, because CT scan is kind of gold standard for diagnosis of bronchiectasis. So there are certain specific findings of bronchial dilatation on CT scan. The first one, which everybody has to remember, is a signet ring sign. That means a bronchoarterial ratio of more than 1. There is lack of bronchial tapering. There might be abnormal bronchial contour, and the bronchial wall might be seen till the periphery. There are certain non-specific findings like we saw in the X-ray, peribronchial coughing, finger in glove, that is mucus filled, or multiple air fluid levels. There are certain other findings of small airway disease in many patients with bronchiectasis, and they should also be looked for while you are looking for bronchiectasis, which would include a mosaic perfusion, air trapping, and tree in bed opacities. The important part of CT scan is a lot of times CT scan gives you clues towards the presence of bronchiectasis along with the etiology of bronchiectasis also. So we will see some of the CT scans and see how it looked like on a CT scan. So this is the classical appearance of a signet ring sign. You see there's a dilatation of bronchus, and there is a vessel which is smaller than the bronchus. So this is called as signet ring sign. Very classical sign, and still considered one of the gold standard signs of diagnosis of bronchiectasis. Other signs would include a non-tapering bronchi. Non-tapering bronchus, you can see this right lower lobe bronchus, which is like a cylinder-like. So this is a non-tapering bronchus. Also in the another one, you can see a lot of non-tapering bronchi as well as the varicoid appearance. So that's a bronchiectasis. Now in this scan, you can see that that the peripheral airways can be seen within 1 centimeter of costal pleura. So this is also a sign of bronchiectasis, which is not very less appreciated or reported by the radiologist, but is important. When you see a patient scan, you look for whether you can actually see the periphery having the airways. Now, altered bronchial contour. That means a normal smooth bronchial wall might be replaced by some sacculations in its wall, some irregularity in the wall thickening, or it might be non-tapering. So these are all features of bronchiectasis in different types of patients. This is bronchial wall thickening. So you see in this right lower lobe, very classical. You can see some of the signet ring sign also. But what is very important is that the generally bronchial wall is just minimally perceptible. If it is very well visualized, it is generally thick bronchial wall, which is one of the characteristic feature of bronchiectasis. So early bronchiectasis, that means when the patient is going to develop bronchiectasis, initially they may only have bronchial wall thickening, and bronchiectasis may actually develop a little later in the course of disease. So early identification of bronchial wall thickening, specifically in patients who have COPD or asthma or rheumatoid arthritis. If you see airway wall thickening, then you have to think that this patient is going towards development of bronchiectasis in future. Air trapping, that means mucus, this mosaic attenuation can also be seen on an expiratory scan in patients with bronchiectasis because of the small airway involvement in a large number of patients with bronchiectasis. Mucus plug infection, this is, if you see on the image on the right side, this is the finger in glove appearance, and this is a classical appearance in patients with ABPA. You see the high attenuation mucus. So what is important that this is a non-contrast scan, and you can see this white thing inside the bronchus, that is the high attenuation mucus. So mucus impaction is also a telltale sign of bronchiectasis, but many a times mucus impaction can be seen in bronchial tumors or a proximal bronchial stenosis, which can lead to a distal airway filled with mucus. You can have a mucus bronchogram kind of appearance, even there is no permanent dilatation. So there is a dilatation in those situations, but that is not a permanent dilatation of the airway, which is the definition of bronchiectasis. Sometimes you can find the air fluid levels during the exacerbation times, or even in patients who are stable, they may have some degree of air fluid levels with bacterial infection chronically in these cavity, in this bronchiectatic areas. Tree in bud appearance is not classical of bronchiectasis, but a lot of patients with bronchiectasis will have small airway involvement, and secondary infections will have tree in bud appearance. So presence, like if you see CT scan like this, you see a lot of signet ring sign, you see bronchial wall thickening, you see the periphery of the lung has airways, that is bronchiectasis, and you see a lot of tree in bud. So that's part of the secondary infection as well as the mucoid infection in the small airways, which is leading to tree in bud opacities in patients with bronchiectasis. This is a very classical scan, which I thought I'll show to you. This is a Mounier-Kuhn syndrome, which is a cause of bronchiectasis. So these patients have tracheobronchomegaly. You can see the trachea is very large in diameter. The bronchi are very large in diameter. So this large diameter leads to, this happens because of the weakness of the tracheobronchial wall, which leads to impaired mucociliary clearance and is associated with bronchiectasis. So all patients with bronchiectasis, you should look for tracheal diameter, bronchial diameters, and many times it is actually missed and thought to be idiopathic, but some patients may have a congenital bronchiectasis due to Mounier-Kuhn syndrome. So now we have talked about many radiological signs of bronchiectasis, and the key bronchial sign, CT scan sign, is the bronchial arterial ratio more than 1. But many a times it is not truly diagnostic. So sometimes it can overdiagnose bronchiectasis. So like in patients with ILD or emphysema, when there is pulmonary fibrosis, there is something called as traction bronchiectasis, which is actually not a truly bronchiectatic syndrome. So in these patients, once there is fibrosis, there is dilatation, but that's not a clear-cut bronchiectatic syndrome. Sometimes in elderly individuals, the bronchi may dilate without any symptoms, so it may be overdiagnosis of bronchiectasis if you use this definition. Sometimes cystic lung diseases like UIP pattern ILD, or if you see extensive honeycombing, they may be reported as bronchiectasis while they may actually be cysts in the lung. In patients who have hypoxemia, they may have hypoxic vasoconstriction of pulmonary artery. So in that case, what happens that the pulmonary artery looks smaller and bronchial diameter looks bigger, and they may be diagnosed as bronchiectasis while actually they do not have bronchiectasis and their bronchi are of normal size. And sometimes you can have a non-tangential CT slice. So I'll just show you an image, which is very good. I wanted to show you. So if you see this image, you see this image, this is actually side image. Okay, so in this you see the vessel is here, but sometimes if you have a non-tangential cut, sometimes you can have a bigger looking bronchus, but which may not be a true bronchiectasis. So a good CT scan reading is important for true diagnosis of bronchiectasis. Sometimes this definition may underdiagnose also. Supposedly you have a patient who has pulmonary hypertension, pulmonary arteries are dilated, they also have bronchiectasis, but because pulmonary artery is too big, accompanying artery, so you will not diagnose the patient as bronchiectasis if you continue using this criteria of bronchial arterial ratio more than 1, or if your CT scan is not of good quality, you may miss bronchiectasis. So I just wanted to highlight these things because all radiology should be interpreted with a correct clinical context to reach a correct diagnosis and management plan. So you can encounter patients with bronchiectasis in two settings. One is you got a CT scan done for something and there is incidental evidence of bronchiectasis. That means patient has a airway diameter more than 1, or there is lack of tapering of airway, or there is visibility of airways in the periphery. If that happens, then you have to look whether patient has those three things which we talked about in the beginning: a cough on most days, a sputum on most days, or a history of exacerbation. If patient does not have it, then patient has only radiological bronchiectasis without a clinical syndrome. If patient has these, then it is called as the clinical bronchiectasis. Now, the second scenario is you have a clinically suspected patient of bronchiectasis. You see the patient has two of these three symptoms. Yes, you got a CT scan done. CT scan shows you these findings, then you call it a clinical bronchiectasis. Supposedly, you think of bronchiectasis, CT scan does not show this, then you have to look for alternate etiology of patient symptom, and it is not bronchiectasis. So till now, I have talked only and only about how do you diagnose bronchiectasis, which is primarily based upon a CT scan and the clinical symptoms of cough, sputum, and exacerbations. Now we talk about the causes of bronchiectasis. And when I have brought this slide specifically and brought these names written here and there, because bronchiectasis has a wide variety of causes, and whatever we kind of investigate, many times we miss a lot of these. Okay, so it can be structural lung disease like William-Campbell or Munier-Kuhn syndrome, or sometimes the collagen vascular diseases like Ehlers-Danlos syndrome. Mucociliary defect, that means primary ciliary dyskinesia or secondary disease, or CFTR mutations in cystic fibrosis can lead to bronchiectasis. Immunodeficiency disorder. So this is one of the uh, very underdiagnosed cause of bronchiectasis, at least in our country, like CVID or X-linked disorders or chronic granulomatous disorders or hematological malignancies. Many times post bone marrow transplant also patients develop bronchiectasis. Infections. So in the infections, because we know bronchiectasis is a chronic bacterial infection of the airway. So many a times, a lot of childhood infections predispose to development, like lobar pneumonia or viral pneumonias in the childhood, tuberculosis, non-tubercular mycobacteria. Childhood measles is one of the common cause of bronchiectasis in our country. Childhood history of whooping cough, which leads to airway damage. And as the child develops, they develop bronchiectasis because of recurrent infection. So a childhood viral pneumonia, childhood bacterial pneumonia, childhood tuberculosis is a common cause of bronchiectasis in our country, and many times it is labeled as idiopathic. Obstructive airway disease like asthma, COPD, or toxic damage, GERD, IBD. IBD is also not an uncommon cause. We see a lot of IBD associated bronchiectasis in our clinic. Yellow nail syndrome, connective tissue disorders. And if you don't find anything, then you label it as idiopathic. But the EERs also recommends that the term idiopathic should be avoided, and all efforts should be made to diagnose a etiology of bronchiectasis. So how do we diagnose the etiology? So when you have got a CT scan X-ray done, you have found the patient has bronchiectasis. So there are two things which you should do for all, that is spirometry and a sputum examination, including for tuberculosis. That is for everyone. Now, you can, based upon the symptoms we'll discuss further, you can do sweat chloride testing, immunoglobulin levels, alpha-1 antitrypsins. For primary ciliary dyskinesia, you can do nasal NO or connective tissue disorders or a BPA workup. Sometimes if you have childhood history, the primary ciliary dyskinesia is common. If you have pancreatitis, malabsorption, cystic fibrosis, recurrent infection, then you think of CVID. If you have upper zone bronchiectasis, it is ABPA or middle lobe or lingular, then NTM, Muir-Kuhn we have discussed. So I'll just go to the investigations. So bronchoscopy is required for a very small proportion. If you have a localized disease and you have to rule out a endobronchial lesion or a foreign body. And sometimes patients who are not producing good amount of sputum, specifically in the NTM disease, you may have to do a bronchoscopy for a lavage or a washing to send it for cultures. Okay. Also, during bronchiectasis evaluation, we have to look for patients who are at high risk, like patients who have COPD, primary ciliary dyskinesia, RA, who have pseudomonas colonization, recurrent exacerbations, NTM or AVP. These are the high risk patients who will worsen with bronchiectasis, and these patients should be managed on priority with a very frequent follow-up and a frequent sputum examination. Also, all bronchiectasis patients should be evaluated for comorbidities, including cardiovascular diseases, osteoporosis, anxiety, depression, rhinosinusitis, GERD, and malnutrition, because they lose a lot of protein in the sputum. Now, this slide summarizes the investigatory plan, and I'll just spend a minute on this slide. So when you have a patient who has bronchiectasis, you do full blood count, serum electrophoresis for complications in terms of secondary amyloidosis. You look for ABPA, you look for immunodeficiency by immunoglobulin, and you do sputum examination for NTM. This is for all. Now, if you have upper lobe dominant early disease, you think of cystic fibrosis and you evaluate for that. If you have middle lobe dominant disease, or if you have neonatal RDS, chronic rhinosinusitis, you think for PCD, you do a nasal nitric oxide. You can do which, so if it is low, that tells you it is a primary ciliary dyskinesia. You can do a high-speed video microscopy of the nasal mucosa to look for the ciliary motility, which can be seen on transmission electron microscopy. Also, you can do genetic testing for PCD. If you have a middle lobe bronchiectasis, think of NTM and do a bronchoscopy. If you have associated autoimmune symptoms, you test for autoimmune disease, primarily rheumatoid arthritis and Sjogren's syndrome are the two diseases which are commonly associated with bronchiectasis. If you have associated emphysema, history of smoking, you think of COPD, or you might many times have alpha-1 antitrypsin deficiency. And if you have recurrent upper respiratory infections also, you think of immunodeficiency and look for immunodeficiency in these patients. This was about the diagnosis of bronchiectasis and the etiological evaluation. For severity, we have a couple of scales. So the most common is the bronchiectasis severity, which has multiple things. You calculate a score, and based upon that score, you can actually prognosticate your patient. Another scores are FACIT score, which includes FEV1, age, colonization by Pseudomonas, radiology, or dyspnea, and another that is EFACIT, which includes the history of exacerbation also. So these are many scales for severity assessment in patients with bronchiectasis. So I'll just stop here, and what we have discussed is that a correct radiological and clinical diagnosis of bronchiectasis is key for the management plan. You should do a radiology as well as functional evaluation in terms of spirometry for all, sputum for all patients. Other investigations, as we discussed, can be done as needed. Comorbidities should always be looked for, because many times we miss the associated comorbidities, which are the common cause of death in these patients. And severity assessment is essential for follow-up and prognostication of these patients. So that's all from my side. Thank you.
That was an excellent talk, Dr. Saurabh. I think you've beautifully elaborated the symptoms, radiological findings, investigations, and how essentially one should approach a case of bronchiectasis. The very basics to the most comprehensive evaluation, so that the correct etiology of bronchiectasis is understood. The reason for us to understand the correct etiology of bronchiectasis is so important, because the treatment direction and the prognosis takes us over there.
Fantastic talk by Dr. Saurabh Mittal. Now I've got an exciting panel with me. We've got 4 stalwarts who will be engaging and brainstorming with me. And without wasting further time, I'd like to invite our first panelist, Jyoti Patnaik, madam. Madam needs no introduction. She's the faculty and Department of Pulmonary Medicine at the Ashwini Group of Hospitals. She's a former professor and the head of Department of Respiratory Medicine at the Cuttack Medical College with a teaching experience of more than 34 years. Is a fellow of the NCCP, a member of the ICS, IAB, ISCCM, ISSLC, OCS, and IMA. Was the past president of the OCS and ISSCM, the Cuttack branch. Has multiple publications in national, international, and state journals. Is the editor of the Emergencies in Pulmonary Medicine and has a chapter in Compendium on HIV and TB. A prolific teacher and has trained scores of respiratory medicine students under her. A warm welcome to you, madam.
Thank you, Dr. Avya, for that introduction.
We have Dr. Ram Prasad, PL, next. Dr. Ram Prasad is an associate professor of respiratory medicine at the Wells Medical College, Tiruvallur in Tamil Nadu. Is an MD DNB, has an European diploma in adult respiratory medicine, is a member of the National Academy of Medical Sciences, has done his diploma in allergy and asthma from CMC, is a member of the American Academy of Allergy and Immunology and the Academy of Allergy and Clinical Immunology. Is a consultant pulmonologist at the Prasad Super Specialty Hospital, Chennai, and is a keen interest in bronchiectasis and management of obstructive airway diseases. Welcome to Dr. Ram Prasad.
Thank you so much, sir. Thank you for the intro.
Next, we have Dr. Ayush Pandey, who's a consultant pulmonologist at the MGU Group of Hospitals at Bhopal. Dr. Pandey is an MD FICS FEP. He's a program director, has a fellowship in respiratory medicine and a fellowship in sleep medicine in association with the Malvanchal University in India. Is an organizing board member of the Fellowship in Respiratory and Critical Care FRCC, organized by the World Institute of Critical Care and Emergency Medicine USA. Is a USMLE faculty, a National Board of Medical Practitioners USA, is a faculty of palliative care for TIPS India. Filed and granted 5 national and 1 international patents in pulmonology by Indian Patents Office, Government of India, and 1 by the Government of United Kingdom. A digital medical educator with over 1.6 lakh followers, and an extremely strong social media presence, and an author of 3 books and published 15 research articles in national and international journals, and a peer reviewer at Serious Journals USA, IJTB India, BSDGA London. Warm welcome to Dr. Ayush Pandey.
Sir, thank you, Dr. Avya, for the very warm welcome and introduction.
And finally, we've got the most important person in the room, as I would like to call it in bronchiectasis, is Dr. Sejal Bheda Gogri, who's a physiotherapist. I've worked very closely with her, and almost everyone in Bombay has. She's graduated from cardiorespiratory physiotherapy from KEM, is the founder of the Care Physio and Rehab, a specialty clinic for cardiopulmonary rehabilitation at Sion. Since 2020, is actively involved in treating patients suffering from bronchiectasis, hyperventilation, COPD, ILD, and chronic respiratory disorders. Was felicitated by the governor of Maharashtra in 21 at Raj Bhavan for contribution during the COVID pandemic. Actively involved in academic training activities for undergrad, postgrad students, and is a guest speaker at physiotherapy colleges, conferences, and workshops, and has published numerous articles in national and international journals. Welcome, Sejal.
Thank you for the kind introduction, Dr. Avya. Now it's my privilege to introduce my friend, Dr. Avya Bansal, who actually needs no introduction. He's a charismatic speaker and an excellent moderator, a consultant pulmonologist and sleep disorder specialist at Bombay Hospital and Medical Research Center, honorary pulmonologist at Mumbai Police Hospital, and has his own setup at Lung Care Clinic, Bandra, which is in Mumbai. He's the recipient of Sir Ratan Tata Scholarship for his MBBS and has been a university topper for his MD. He is a recipient of very prestigious ICS ERS travel grant for the best paper at Madrid Congress 2019. His special interest lies in OAD, OSA, and ILD. He set up the adult vaccination OPD at Bombay Hospital along with sleep clinic and severe asthma clinic to provide state-of-art care at for his Mumbai patients. And also those who are coming from outside Mumbai, because Bombay Hospital is very busy with patients all over India and abroad. So that's Dr. Avya. And thank you for being the moderator for today's session. Thank you.
Thanks, Sejal. You've been very kind. Now, we've had Dr. Saurabh educate us and tell us about the diagnosis, symptomatology of bronchiectasis. Now, for the benefit of our audience, I've prepared a few questions which we've received upfront from our logins and a lot of questions which I feel need to be addressed in today's session on bronchiectasis. Now, Jyoti madam, I'd like to begin with you. Since you've been a teacher to almost all of us and you've been practicing for more than 35 years, what are the underlying causes of bronchiectasis which you've seen evolve as the knowledge of the disease has changed in the last 30 years of respiratory medicine?
Dr. Mittal has very nicely put up a slide regarding this. That was an excellent slide. That in one slide he told all the causes. What has been evolving as students, we used to know that childhood severe pneumonias, severe infections, chest infections will subsequently lead to bronchiectasis. That was what we all knew. And post-tubercular bronchiectasis is a common condition that we always come across after the tuberculosis has been taken care of and the patient is disease-free from tuberculosis but never symptom-free because he continues to have bronchiectasis as a symptom that brings him to the hospital. Then, as he has already mentioned, certain diseases like CTD, which is accompanies this chest symptoms like in rheumatoid arthritis, Sjogren syndrome, scleroderma, dermatomyositis. These are all conditions where we will be getting bronchiectasis. So there are a multitude of predisposing factors. Even conditions like COPD, long-standing asthma, badly managed. When it is badly managed, there are some structural damages that will then manifest as bronchiectasis. Then we also have, as he already mentioned, the inflammatory bowel disease, the GERD, and then other diseases like primary immunodeficiencies and secondary immunodeficiencies. Under primary immunodeficiencies, very commonly we can see the common variable in immunodeficiency, agamaglobulinemia, and the other secondary immunodeficiencies, malignancy, chronic corticosteroid use, or some cytotoxic drugs, or HIV, CMV. These are all conditions where we can see bronchiectasis. So bronchiectasis is not so uncommon and not an orphan disease as it used to be seen in the Western literature, which used to surprise, I think, most of the doctors from India, because we see it so often and it is one of the best cases that is given to the students during their examination.
So very well said, madam. I'd like to, for the benefit of audience, enlist and tell them that whenever you see an immunodeficiency status, it could be primary or acquired. Whenever there's infection, tubercular or non-tubercular or bacterial or fungal, whenever there is impaired mucociliary clearance and inflammation of the lungs. When you see these four primary pathologies in a patient, you should suspect bronchiectasis. Whether it's tuberculosis, non-tubercular mycobacteria, ABPA, impaired mucociliary clearance because of Cardigan's syndrome, cystic fibrosis, there's structural damage of the lung, inflammation inside the lung, and colonization with bacteria. So this forms the cornerstone of all pathological aspects of bronchiectasis. Dr. Ram Prasad, could you tell us the radiological classification of bronchiectasis for a benefit of our listeners, which we've learned over the years?
Yeah, so good evening to all the panelists and the moderator. As Sir has already presented the three radiological types of bronchiectasis, the cylindrical type, which is the most common type, what we already know, also known as tubular bronchiectasis. So this has a uniform dilatation of the bronchi and the typical track sign, also known as signaling sign, that we already see in the CT scans, HRCT probably, and it is the mildest form. And the second time is the varicose type, so which is intermediate severity, which is irregular alternating dilatation and narrowing of the bronchi and has a beaded appearance. So entirely the bronchi is totally distorted and mostly seen in our post-TB, which we probably encounter in our Indian scenario cases. The third type, the cystic or the saccular type. So this is the most severe type because there is a higher chance of mucus retention. The mucus plugging happens. The patient retains the secretions again and again, leading to pseudomonas colonization also, which we already know is a most common persistent cause of recurrent exacerbations and hospitalizations. So the air fluid levels and cluster of grape appearance, as described in Procter and Douglas and other books, etc. So this also has a very bad prognosis. So as such, every bronchiectasis has a definite tailored management also. And these are the typical types that have been mentioned radiologically.
Very well said, Dr. Prasad. We should also remember that traction bronchiectasis is not a classification of Reed's classification of bronchiectasis. Traction bronchiectasis is nothing but distortion of the airways which is being pulled outward because of some form of scarring of fibrous tissue. So this doesn't form as the conventional classification of bronchiectasis, which is cylindrical, varicose, and cystic.
Cylindrical, varicose, and cystic, yeah.
Yes. Dr. Ayush, could you tell us about the pathophysiology of bronchiectasis? We've spoken about the causes of it. What are the radiological features on a CT? How does bronchiectasis actually occur?
Yeah, first and foremost, it was a very refreshing talk by Dr. Saurabh Mittal, sir, on bronchiectasis. And just, it reminded me of my MD days, where in paper 4, that Moyneux-Kuhn syndrome question popped up. And we were like, are we giving paper 1 again? Because paper 4 was supposed to be recent advances. Coming back to our question of pathophysiology of the bronchiectasis. So as it is a chronic heterogeneous airway disease caused by irreversible bronchial dilatation, and the evaluation of concept has changed from the vicious cycle to the vicious vortex. So the traditional cycle has described it a sequence of impaired mucociliary clearance, structural damage. But if you look at the current concepts, it has evolved to the vicious vortex. That means multiple processes are occurring simultaneously and they are reinforcing one another. So if you look at the major pathophysiological mechanisms, which is often the initiating agent is the impaired mucociliary clearance, maybe because of the previous respiratory infections, cystic bronchiectasis, or primary ciliary dyskinesia. Then you have a chronic airway infection because of the persistent bacterial colonization. And bronchiectasis, as it is a neutrophilic inflammatory disease, so there is activated neutrophils that release neutrophil elastase. There is a release of the reactive oxygen species, matrix metaproteinase, and these mediators, they destroy the elastin cartilages. They also impair the ciliary function, and they also promote the airway remodeling. So airway remodeling is also, that leads to bronchial wall thickening. It leads to loss of the cartilage, airway trapping, and of course the microbiome dysbiosis. So patients with reduced microbiological diversity or dominant Pseudomonas aeruginosa infection, and of course the immune abnormalities that Dr. Saurabh discussed can be the contributory cause. But again, the management will be discussing that. And this was also the talk of the World Bronchiectasis Conference that was recently been conducted in Hamburg, Germany in June 2026. And the talk of this one major drug was the brensocatib, which is the DPP1 inhibitor, and that is based on the mechanism, like it inhibits the activation of neutrophil serine proteases, including the neutrophil elastase. So this is all about pathophysiology of the bronchiectasis. So neutrophil elastase is emerging more kind of a therapeutic target and biomarker, and precision medicine and more kind of a microbiological guided therapy and assisted imaging are definitely the future directions of it.
So very well said, Dr. Ayush. I'm so happy that you've spoken about the vicious vortex. We progressed from the vicious cycle and involved the infection as a part of the vicious vortex, because inflammation, infection, impaired mucociliary clearance, and lung damage, it's like the chicken and the egg. Which starts first? All 4 corners are equally important. And we need to break this cycle or conundrum where one aspect of inflammation, infection, mucociliary clearance, and lung damage conversely affects the other, and there's a gradual progression of the disease. We've often spoken about stability of disease in asthma and COPD, but achieving stability of bronchiectasis by breaking the chink in this armor is so important and yet often neglected and difficult. Sejal, now we've spoken about pharmacology a lot. Just can you tell us what are the non-pharmacological treatment approaches for bronchiectasis? When we talk of a irreversible, progressive kind of a disease, your role becomes so very important.
Yes, Dr. Avya. As our esteemed speakers and panelists have already highlighted, that main problem with the bronchiectasis is increased secretion, retained secretion, infection, and inflammation. Hence, the airway clearance techniques and the strategies remain the cornerstone, mainstay non-pharmacological treatment. Apart from that, proper humidification, good hydration, oral hydration, along with that, good pulmonary rehabilitation to improve the ventilation, to improve the exercise capacity and quality of life remain very important and highly recommended. Along with that, inspiratory muscle training has emerged as a very important tool in strengthening the respiratory muscles. Oxygen therapy via normal nasal bronchs or high flow nasal cannula also remains important in certain population, which desaturates easily during exertion or at rest. Non-invasive ventilation in some substrate of the patient who actually desaturates. It helps in the airway clearance, and it keeps the airways open with its positive airway pressure. So in some patients, it also reduces the work of breathing. So we can definitely use this as an adjunct. Patient education as a non-pharmacological mode of treatment remains very important, because once the patient is empowered with the right knowledge and skill to manage its own condition, then the adherence and compliance improves for the overall treatment. Lifestyle modification, like smoking cessation, good diet and sleep remains very important for recovery. Nutrition remains very crucial, because lower BMI has worse prognosis, and also the respiratory quotient needs to be monitored, because higher carbohydrate diet, which is typical Indian diet, creates more carbon dioxide production and hence increases the work of breathing. And these patients are respiratory system is already taxed so much. So all these adjunct treatment can give a good result in overall treatment and management and counseling for patients having signs of anxiety and depression. So there's a lot to be done in this patient, and we need to focus on non-pharmacological treatment also.
Very well said.
Thank
Pulmonary
you.
rehabilitation and physiotherapy are so very important when we speak of exercise, exercise tolerance, improving airway clearance, vaccination, nutrition, and counseling. It's as important, sometimes more important than pharmacotherapy, because there are so many drugs in our armamentarium. We don't have more medication, we don't have more treatment to offer. But rehabilitation in bronchiectasis comes a long way and should be a never-ending process for these patients. Saurabh has beautifully spoken about the etiology of bronchiectasis, but now if I have a resource limited scenario and I don't have a resource limited scenario, Saurabh, I'm giving you two situations as most of us see in our OPT practice. The first situation is a resource limited setting. What would be the tests which would be absolutely mandatory when you have a patient of bronchiectasis, and what would be the additional tests where you're free to evaluate the way you want it?
So, I mean, the minimum, of course, we have diagnosed bronchiectasis based on a CT scan. So that's already done. So, I mean, the minimum first is, of course, you have to do a spirometer to look at the lung function. That is one thing. Then you have to do a sputum examination. So how extensive you want to be, that depends upon your. So generally, we perform at least a bacterial culture, a fungal culture, a non-tubercular mycobacterial culture, and a gene expert and MGIT culture. So that is the minimum we should do for even if you have a resource limited setting for functional evaluation. For etiology, a lot of things you will find from the CT scan. Then you have to minimum do an ABPA evaluation by as per the specific IgE, IgG, and a total serum IgE. You need to perform a eosinophil count. You need to do at least immunoglobulin IgG, IgA, IgM levels. So that is something which is minimum. Other investigations you can do based upon your clinical suspicion. If you have early onset, you have to think of cystic fibrosis. If you have malnutrition, you have malabsorption or pancreatitis or early onset diabetes, then you think of cystic fibrosis and evaluate. If you think of an autoimmune disorder, patient has joint symptoms, also you think of RA or Sjogren's syndrome and evaluate from that point. So, I mean, from the point of view of primary ciliary dyskinesia, if you talk about nasal NO or the high-speed video microscopy, they are sophisticated tests and may not be available in all settings. So that depends upon the availability of test. If you do not have, and if you have a suspicion, you should always refer the patient to a center where a proper etiological diagnosis can be made, because Generally, management can be done at secondary, tertiary level. Secondary level also, if you have kind of had a plan in your mind. But an investigatory plan, patient may have to go to a tertiary center if you have not found a etiology from the basic evaluation done at primary or secondary level. I think one thing which is very often missed is a good history taking. That means you have to find out whether they had a childhood infection, whether they have joint symptoms, whether they actually have a relative who had bronchiectasis. So there are a lot of things which are missed in history. And if you take a good history, you'll be able to pinpoint uh, towards a etiology just by looking at your radiology and your history.
Very well said, Saurabh. I think in India, the boon and the bane has been tuberculosis. Every time the bronchiectasis patient comes to us, we start digging for tuberculosis, but very often we don't try to understand why tuberculosis occurred in the first place. This patient could have had a primary immunodeficiency or an acquired immunodeficiency and developed tuberculosis later on, and probably that's the reason why he developed bronchiectasis in the first place. Also, another test which is not routinely done because of cost is a whole exome sequencing. Very often, genetic mutations such as CFTR, even the minor ones, are picked up on a whole exome sequencing. You don't really need the major mutations to have a significant impact that's typically seen in the early years of life. But towards the later years of life, where you've got a minor deletion, the bronchiectasis can flare up. Immunodeficiencies can be picked up on a whole exome sequencing. So understanding the etiology of bronchiectasis becomes so very important is because your entire treatment is dependent on the etiology. Unless you treat the primary trigger factor of bronchiectasis, you're never really going to help the patient. If rheumatoid arthritis is the cause, unless you treat the arthritis, you're not going to take care of bronchiectasis. If COPD is the cause, you're not going to treat COPD. The bronchiectasis is going to keep worsening. So understanding the etiology and investing heavily on the diagnosis of bronchiectasis becomes important because the cost of therapy would be minuscule as compared to the recurrent exacerbations which the patient would encounter. Jyoti madam, could you tell us once again about bronchiectasis severity index, BSI, and why is it so important for all our patients to be calculated and scored as a BSI upfront and on follow-ups?
So bronchiectasis severity index is a risk stratification tool, and that is to assess the risk of morbidity and mortality in bronchiectasis patients. These assessments serve as a valuable tool for guiding the intensity of treatment and resource allocation. Up to 2014, there was no such validated tool. After 2014, a large European study was done to develop this bronchiectasis severity index, which is using around 9 parameters like age, the BMI of the patient, FEV1, then the previous hospitalization, the annual exacerbation frequencies, the MMRC score, then colonization status. 1 point goes for Pseudomonas alone and another point for other infections. Imaging findings, all these are together used to calculate the 1-year mortality and hospitalization, again 4-year mortality and hospitalization, and they are calculated as mild bronchiectasis and mild, moderate, and severe bronchiectasis. So this is a stratification that can be used to for resource allocation and management of these patients. And we have another score also, that is the phased score, where the FEV1, age, and the chronic colonization, and the dyspnea are taken. But here it is not well validated because the exacerbation history is left out, which is one of the main features of deterioration in a case of bronchiectasis.
And we score the patients as mild, moderate, severe, depending on score of 0 to 4 becomes mild, 5 to 8 becomes moderate, and a score of more than 8 becomes severe. So it's important for us to score these patients of BSI at every visit because that's how we understand. Sometimes we may miss a particular point about the severity of breathlessness. A 1 to 3 may suddenly become 4 or a 5, and a hospital exacerbation in the 12 months often missed by us would be very, very important. A sudden change such as the BMI changing from 18.5 plus or minus, that could change your BSI. So certain things need to be looked at very closely when we talk of BSI. Dr. Ram Prasad, we know airway clearance and mucus is such a big problem in bronchiectasis. So what is the role of mucoactive drugs in bronchiectasis, and could you enlist a few mucoactive drugs which you use commonly in your practice?
Sure, sir. So the mucoactive drugs are not like typical therapeutics. They are quite adjuvant to our routine practice and routine therapeutics, what we use. The main function of the mucoactive drugs is to reduce the mucose viscosity, improve the sputum clearance so that the patient doesn't get repeated exacerbation due to retention of secretions. So basically, we facilitate the mucociliary clearance. So we have few other options what we routinely use. I mostly use oral mucoactive agents such as N-acetylcysteine and the newer molecule like eridostine, though that has recently launched also. Other than that, we have hypertonic saline, usually 3% or 7%. And as per literature, we have alpha dornase, which is usually used in cystic fibrosis. And I think it's not currently available in India as far as I know. So mostly I use the oral agents such as N-acetylcysteine and eridostine. So that is mostly works well for most of the patients, along with the routine chest physiotherapy and mucociliary exercises.
Very well said that we use N-acetylcysteine. We've been using it for the longest time. We've got eridostine, which is a reinvented molecule. We also use ambroxol in this nebulized form or in the syrup form. We've got a 3%, 5%, 7% hypertonic saline, which also works very well in making the mucus thin. We've got N-acetylcysteine in the form of a nebulized medication as well, which can be given while patients have having excessive mucus which is clogged in the airway. Just a word of caution, sometimes mucoactive drugs can cause a reflex bronchospasm. Typically in the nebulized form, more commonly seen with hypertonic saline and N-acetylcysteine nebulization. So that's something we need to be really careful. And also sometimes they can give rise to hemoptysis. So in bronchiectasis and hemoptysis is a catch-22 situation. The mucus plugging would cause further damage and hemoptysis, and the mucoactive drug would cause hemoptysis as well if a clot is dislodged. Moving on, we've spoken about how the West called bronchiectasis an orphan disease, and there's been a lot of clamor and talk about using the Indian diaspora and the Asian population as a benchmark and understanding bronchiectasis in Asia. So, Dr. Pandey, how is Asian bronchiectasis different from the West?
Thank you, Dr. Avya, for this interesting question. Now, if you look at the bronchiectasis, especially in Asia, it differs in epidemiology, etiology, microbiology, and definitely outcomes also. So if you look at the major differences, yes, in Asian, the post-TB or the post-tubercular bronchiectasis, which is the hallmark of the Asian bronchiectasis, we have high burden of NTM disease. Asian countries do report, you have MAC, you have Mycobacterium abscessus, fungal disease. So again, a greater burden of ABPA, chronic pulmonary aspergillosis, sensitization, aspergillus sensitization, and environmental factors like biomass, fuel exposure. We have air pollution, even indoor smoke is also there. And again, this was the talk of the discussion even in the WBC 2026. Compared with the Western populations, Asians do have more chronic pseudomonas, more NTM, more multi-drug resistance organisms. But if you look at the major, key features or key differences between the Asian and the West, so NTM prevalence, yes, higher in the Asian as compared to West. When we talk about the testing, so CF testing and alpha-1 antitrypsin testing, which is rarely, done or rarely performed maybe in Asian settings, that have been frequently or routinely performed in the West populations. When we talk about the, macrolide therapy, yes, TB and NTM has to be excluded before the initiation of any of the therapy in the Asian settings, and NTM exclusion is definitely emphasized with respect to the West, but TB is of course a less of a comparison concern with respect to the Western population or settings. So accordingly, with the Indian settings, the lung transplantation, again, we have limited access, but now we have come up with so good centers that are being again performing lung transplantation, and the West we have definitely a well-established services. So overall, with respect to the testing, with respect to the etiology and respect to the epidemiology, this is the basic differentiation from the Asian perspective of bronchiectasis from the West.
Yeah, also our BMI is it's lower, so we see a lot of thin bronchiectasis patients in our population, and there's also a lot of discordance between the severity of disease and the symptoms of the patient. Very often we have patients whose disease is extensive and the symptoms do not correlate with the severity of the diseases, and they often tell us that, listen, I'm used to living with this mucus production, Yellow-green sputum happens whenever the season changes. Why are you making such a big deal about it? So there's a discordance between the severity and the symptomatology of patients which we see in our Indian population. And like I said, the post-tubercular has been downplayed and overplayed when we talk of bronchiectasis, and evidence is lacking from the Indian data. So anyone who's interested in managing bronchiectasis should generate more evidence so we can learn about this disease in our Indian setting. Sejal, airway clearance techniques, so very important in managing bronchiectasis. Just tell us why.
So airway clearance techniques using the basic principle and natural anatomy of our respiratory system, like pores of Cohen's, Lambert, channels of Lambert and Martini, which increases the collateral ventilation and the air goes behind the secretion and just pulls it up with correct breathing technique. And it increases the expiratory flow rate, it increases the mucociliary transportation and hence effective clearance with negligible resources. It can be performed in hospital, at home, over teleconsultation, anywhere. And it prevents infection, it prevents exacerbation, it delays hospitalization, a number of hospitalization in a year. It's been noted in the research studies. So basically, it helps a great deal in the management of bronchiectasis patients in terms of prognosis and preventing exacerbations and hospitalization, and in some cases even mortality benefit is also noted. So of course it's a big deal because it's again non-pharmacological, no major side effects, no adverse events noted during any of the studies, so it's safe and effective. It reduces the antibiotic usage as well in a lot of patients, and effective self-management helps with, again, the compliance and the adherence to the treatment, the medical as well as non-pharmacological. So there are various techniques like airway clearance, active cycle breathing technique. There is autogenic drainage, wherein we start with the low lung volume, we go to mid lung volume, and then high lung volume. So in that, patient does not really consume too much of energy, and the cough efficacy improves. Basically, the patient is not coughing throughout the day all the time. In that particular session, maximum sputum is being drained out and the efficacy is so good that whole day patient feels better, more energetic, less fatigue, and the overall quality of life is much better. So that way, I think definitely it has its own merits.
The good old postural drainage is what we learned when we were residents and how important it was. Gravity becomes so important. And as doctors, physics is something we were always scared of, but physics really doesn't leave us in management of bronchiectasis, where the vibrations, oscillations become so important in impacting and helping dislodge the impacted mucus from the peripheral airways and helping it cough out through gravity. So physics and respiratory medicine are extremely important when it comes to bronchiectasis management with respect to airway clearance techniques. Dr. Saurabh, elaborate sputum PCR evaluation in bronchiectasis and why is it so important? Why are we always worried about repeat sputum evaluation for our patients of bronchiectasis, either upfront or on subsequent follow-up visits?
So as we discussed previously, so there are at least three things in the bronchiectasis. One is airway inflammation, second is mucostasis and mucociliary clearance problem, and the third is the airway infection. Okay, so this infection part has to be picked up in time and treated. How do we pick it up? So the conventionally we all have used bacterial cultures, fungal cultures, or mycobacterial cultures, which have good specificity, but they have a lower sensitivity for detection of algorithm. Second thing, in bronchiectasis, most often it is a polymicrobial colonization. That means multiple bacteria, multiple fungal species, as well as other organisms are there, non-tubercular mycobacteria of various species. So identifying all these on conventional cultures sometimes may be difficult. Okay, so we don't know whether it will actually change the management plan, but there have been studies now which are looking at the use of multiplex PCR in stable bronchiectasis, whether we can pick up more organisms, whether elimination of those organisms will lead to improved outcome is yet to be studied. What is very well known is if you find Pseudomonas, it has to be treated. So that is there is maximum evidence for Pseudomonas. But yes, sputum examination, if you have facilities, you can go for a biofire or a multiplex PCR of other platforms, but at least a culture repeatedly should be done to look for the organisms, because elimination of this organism is key for prevention of worsening of lung function and exacerbations.
Also, another couple of points is that whenever we've got, suppose, a chronic colonizer with, for example, Pseudomonas, and the patient suddenly tells us there is worsening of symptoms, we repeat a sputum culture and we see the colony forming units. If we see there's a multiple trend or there's an increase in the CFU, so we know that this chronic colonization has resulted in an infection as of now, and probably that's contributing to an exacerbation in the patient right now. Repeated sputum analysis also help us to understand that the patient may not have had NTM in the past, but because of a structural lung damage, the patient can acquire and develop non-tubercular mycobacteria. NTM is something which is very often missed in follow-up cases of bronchiectasis. We very often assume that Pseudomonas is there, so something else can't come. Or if it's a post-tubercular lung, nothing else can come. But sputum conversion or AFB negative to an AFB positive is something which we see when non-tuberculous mycobacteria is there. And we've been spoiled in metropolitan cities with gene expert, and sometimes we forget to test for AFB. I'd like to remind the audience that testing for AFB is very important when we look at bronchiectasis because of non-tubercular mycobacteria. And like Dr. Saurabh rightly said, multiplex PCR help us to identify organisms which would not otherwise be grown on cultures. Growing strep becomes tough, growing Haemophilus influenzae becomes tough. And very often we understand the genetic mutation and the genetic structure of these bugs as well. When we talk of NDM, CTX, OXA, these are all mutations which tell us and help us understand future antibiotics which would be helpful in managing these patients. Coming to Dr. Jyoti, madam, we've spoken about sputum importance and the notorious Pseudomonas. What is Pseudomonas eradication therapy, madam?
So, as we have already discussed, Pseudomonas is one of the most important colonizers, which is responsible for in the risk stratification. So it adds 1 point by itself as a risk stratification tool. So there it is very important that we have to get this organism which is colonizing always in bronchiectasis to be eradicated. Eradicated means to the concept of early and aggressive antibiotic to remove this from the bronchus. So that is the idea. So there has been in both cystic fibrosis and non-cystic fibrosis bronchiectasis, Pseudomonas aeruginosa may be seen as a colonizer. So it is there are various guidelines for this, out of which I will be only discussing the BTS guideline and the ERS guideline. So both these they have given very good suggestions how to do it. And there are 3 options in BTS guideline. First, we will give only ciprofloxacin orally for 2 weeks and then test for the sputum. If this first line therapy has failed and this Pseudomonas is still present, then we'll go for IV anti-pseudomonal antibiotics for 2 weeks. Or if then again it is not clearing the Pseudomonas, then we will go for ciprofloxacin 750 BD for 4 weeks, followed by nebulized colistin for 3 months. This is the BTS guideline. And ERS guidelines have 3 options that they have given. Ciprofloxacin for 2 weeks. If Pseudomonas still persists, followed by IV anti-pseudomonal antibiotics for 2 weeks. And if it still persists, then go for inhaled colistin or tobramycin or gentamicin for 3 months. So the option 2 and 3 are also the same. It's only the intensity of treatment is increasing in these options. And there are many other guidelines like the Spanish guideline, Brazilian guidelines. All of them almost speak of the same method to eradicate this Pseudomonas colonization for a better outcome in the management of bronchiectasis.
So very rightly said, the first isolation of Pseudomonas is very, very important because the success of eradicating Pseudomonas after the first isolation is 40%. Remember, if you isolate Pseudomonas upfront, yet the chances of eradicating it completely from the airway is only 40%. 60% of the time, it would still become a chronic colonizer. Subsequent colonizations have got a lesser impact of eradication of about 10 to 20%, which is why the first isolate should always be eradicated. Madam, I said there are multiple protocols which have been followed. The most conventional and the easiest protocol has been ciprofloxacin for 2 weeks, followed by a 3-month course of inhaled nebulization, typically of tobramycin, unless the Pseudomonas is inherently resistant to tobramycin and it's not a first isolation, and where you could consider colistin or gentamicin nebulization. So simple 2 weeks of ciprofloxacin or a fluoroquinolone or an intravenous antibiotic if the fluoroquinolone is resistant, followed by a 3-month cycle of inhaled tobramycin bar colistin. Conventionally, patients who didn't tolerate a continuous 3-month nebulized cycle were given a 1 month on and a 1 month off cycle. That was a 28-day on and 28-day off cycle. And thereby the entire duration of treatment was extended to 6 months. Current data tells us that the 3-month continuous cycle is better. Very often, the chronic colonizers have been given nebulization for as long as 6 to 12 months to reduce the symptom burden in these patients as well. If at the end of 3 months, the sputum does not turn negative for Pseudomonas, and if the symptom burden remains high, the duration of nebulized therapy is continued purely for reduction of exacerbations and symptom burden and not as a tool for eradication of Pseudomonas in these patients. Dr. Ramprasad, what is the role of long-term macrolides when we talk of bronchiectasis?
So, yes, sir. So, ERS actually recommends long-term macrolide therapy, especially azithromycin and azithromycin are the two most commonly used antibiotics. And ERS recommends if there is a frequent exacerbation, that is more than 3 exacerbations per year, in spite of adequate therapy and mucociliary and airway clearance has been established for the patient. And patients who are having idiopathic bronchiectasis or chronic Pseudomonas inflammation also have a benefit in long-term macrolide therapy. And the usual dose, what is recommended in ERS is 250 milligrams once daily or 500 milligrams thrice weekly regimen. And long-term, precisely the duration has not been prescribed. It is usually given for 6 to 12 months, and it has to be reassessed after that. And for patients who are elderly, who are having cardiac abnormalities, the QT prolongation becomes an issue. So we need to get a baseline ECG, and if the patient develops any kind of arrhythmia, it has to be followed up periodically. And in Indian scenario, non-tuberculous mycobacteria also becomes a concern. So NTM has to be ruled out beforehand, or as and when if the patient gets exacerbations, NTM cultures has to be sent as and when required also.
Yes, very well said that we must rule out first non-tubercular mycobacteria because it's an important drug. Macrolide becomes one of the most important drugs while dealing with NTM, and MAC is something we see so often, and azithromycin is important. Another important point we need to remember is sometimes long-term macrolides can impact the hearing as well, which is why a pure tone audiogram or a PTA should be done before you start the patient on long-term azithromycin prophylaxis, and probably a 3 to 6 monthly checkup with an ENT or simple a PTA should be done with documentation that the hearing is not impaired by the macrolide. The macrolide over here more so works as an anti-inflammatory drug by reducing the inflammation in the lungs and the airways, and thereby having an important aspect of that vicious vortex. Conversely, the long-term antibiotic also takes care of little nitty-gritty infections which the patient may encounter and therefore prevents an indirect exacerbation. So the long-term macrolide helps in improving the exacerbation risk of bronchiectasis patients, and Dr. Ramprasad has beautifully elaborated the entire process. Moving from one antibiotic to another, Dr. Pandey, 2 questions to you. Should long-term inhaled antibiotics be used in bronchiectasis patients even when eradication is not possible? And is there any role for non-macrolide long-term oral antibiotics in bronchiectasis?
So long-term, antibiotic therapy definitely aims to reduce bacterial burden, prevents the exacerbation and slowing of the disease progression. But again, it should be only considered after the optimization of the airway clearance, when you have treatment of the underlying causes, the vaccination and the pulmonary rehabilitation. Now, if you look at the ERS clinical practice guidelines of the 2025, long-term inhaled antibiotics to patients with chronic Pseudomonas aeruginosa infection and high risk of exacerbations. So who are the high-risk patients? who are having greater than equal to 2 exacerbations per year or greater than equal to 1 exacerbation requiring hospitalization or even 1 exacerbation plus daily severe symptoms. So considering the inhaled antibiotics for chronic infection with non-pseudomonal pathogens in selected cases can be there at high exacerbation risk. But before initiation of the long-term and inhaled antibiotics, always ensure that the vaccination status, the airway clearance therapy, the sputum cultures confirms the chronic infection, and you have, of course, the exacerbations that persist despite the standard treatment. Now, we have already talked about the, doses part of it. When you talk about your second question of the non-macrolide oral antibiotics, again, going back to the, 2025 ERS clinical practice guidelines that has specifically recommended against their routine use as the first line suppressive therapy because of its limited efficacy, the poor quality evidence has been there even in the trials and research, and more kind of higher adverse effects. So newer alternatives are being developed, and again correlating with the WBC because this was one of the talk of the discussion. So instead of expanding to the oral antibiotic use, the research is now on the more personalized antibiotic therapy that is guided by microbiome analysis, inhaled bacteriophage therapy, inhaled antimicrobial peptides, and biomarker guided antimicrobial selection. So even along with the ERS, the BTS guidelines, if you see again routine long-term oral antibiotics, they have not recommended, but again culture directed suppressive therapy through the amoxicillin or doxycycline can be there. But again, the routine use with respect to the standard guidelines has been against of using them.
Perfect. So use inhaled antibiotics for non-pseudomonas with a high risk of exacerbation and symptom burden, and for pseudomonas for eradication and for symptom burden. That's straight up. Use non-macrolide antibiotics against it. You can't use them unless you've got a minor exacerbation which is caused by a bug, which is not a conventional colonizer. For that, okay, 7 days, 10 days, 14 days, depending on how severe the disease is. Otherwise, it's a strict no. Another point which I'd like to add is when we speak of macrolide antibiotics, it's a clear-cut dictum. Give it for 12 months. If at the end of 12 months the patient responds, continue. You don't want an exacerbation. If at the end of 12 months the patient doesn't respond to macrolides, stop it. So for macrolides, very simple, 12 months. At the end of 12 months, reassess the patient. Patient is responding, continue with the macrolide. If the patient is not responding, stop the macrolide. Sejal, airway clearance, and I'm back to you. We've got so many devices for airway clearance. Tell us how these devices work and which is your preferred device as an airway clearance in India. Now, cost of devices are different. So tell me an ideal device and a device in a resource limited setting.
Sure. So basically, there are handheld devices, there are tabletop devices, there are some wearable devices. Depending on patient participation and affordability, and of course the disease and sputum burden, we can decide which device should be given. Major factor here is the cost and the patient preference. Because only if the patient is preferring to use it, only then they are going to use it. Along with that, certain breathing retraining to be taught before using the device, some breathing technique while using the device, and first expiratory technique to be done after using the device is very important. Then the clearance is effective. The basic principle here is there are some positive expiratory pressure devices which use the principle of positive expiratory pressure to keep the airways open, to increase the shearing forces at the air and fluid interface, and thus loosening out the secretion and effective clearance. There are certain oscillative positive expiratory pressure devices like aerobica, a cappella, flutter devices, and there are many Indian variants of flutter devices now available at a lesser cost, but some of them are gravity dependent, so only if the patient can sit upright for like 15-20 minutes and use it, that can be done. Aerobica and a cappella can be used in any position, which is like lying down, prone, so it can be clubbed with the postural drainage position, Eltgall, that is slow expiration with the open glottis, lateral decubitus position. So in general, in my experience, just one technique or one device does not give optimum result. It's when you use the combination of the things that gives faster and long lasting results. My practice, I've seen all the ranges of devices being used right from the flutter. There is AeroPep device, which is available at a lesser cost. like something like 1,000 to 1,200. Then there is a cappella at around 5,000 and aerobic at around 4,500. So depending on the affordability and ease and convenience, you can definitely go for the different options. High frequency chest wall oscillation is a wearable device that mostly is used in the hospital setting when the patient contribution is not much, when there is the high patient load and a physiotherapist cannot spend a lot of time with that patient, then it's the convenient mode of airway clearance. Mechanical vibrators are also available now. It's a tabletop machine, and there is a head transducer which can be moved on the chest wall that gives external percussion vibration and helps with the loosening out that secretion. Then there is cuff assist. That is like external mechanical insufflation, exsufflation device, which used to be earlier done with the umbo bag, but now there is a sophisticated machine available for that. So that can also be used in the patients who cannot really effectively produce that effective cough, strong cough. So that option is also available. So basically, patient contribution, cognition, affordability, and of course the adherence, the compliance. So all these factors need to be taken into consideration before recommending. But the bottom line is the referral to the chest physiotherapist is important, because how to use this device correctly and the breathing strategies to be used before, during, and after the device is very important. Just the referral will not give the desired output.
What Sejal just said needs to be remembered and echoed by everyone. Do not involve a physiotherapist for the sake of it. Please remember, she or he is the most important person in management of bronchiectasis wherever there is sputum production. Unless we're talking of dry bronchiectasis where pulmonary rehabilitation is as important, it becomes more so whenever there is a lot of mucus which is being produced. Sejal has told us a plethora of devices which are available. The good old postural drainage always remains, and a combination therapy of postural drainage plus a device achieves significant improvement in reduction of symptoms as well as the exacerbation. Indirectly, I mean, I'm sure everybody has heard of the CASA-Q questionnaire, which is being used for COPD, but you can use that questionnaire indirectly even for bronchiectasis and understand the symptomatology and the symptom burden, which significantly comes down in patients who've undergone a rehabilitation program and airway clearance techniques have been taught. Any patient of bronchiectasis without ACT being offered is incorrectly and incompletely being treated. So please have a physiotherapist on board for every bronchiectasis patient. If they can't afford, have a tele-rehabilitation, or probably send them videos on how to do their bronchiectasis sessions themselves, or teach them simple training as postural drainage where the primary caregiver or the help at home or the nursing staff or support staff can perform these exercises for the patient to improve the quality of life in a resource limited setting. Moving on to Dr. Saurabh.
Just want to add,
Yeah,
just
please.
1 or 2 sessions are enough to teach them the basic
Yes.
airway clearance technique. They can record a video of them performing the technique and then do it at home. And you can teach them to the relative as well, who's the caretaker, and they can help the patient at home. And follow-up can be done through virtual tele consultation.
The hybrid model of in-person
Yes,
and
definitely it works
tele-rehabilitation
well.
works very well. COVID has taught that to us. Sort of an important question. We see patients on inhaled corticosteroids and bronchiectasis present to our OPD day in and day out. 2 questions to you. Should inhaled corticosteroids be used in bronchiectasis? If yes, why? If no, why? And should oral corticosteroids be used in bronchiectasis and in which situations?
So inhaled corticosteroids in general should not be used for bronchiectasis. Okay, that is a very blanket statement I would like to make. So when you can use these inhaled corticosteroids if you have an underlying asthma. Okay, so you have asthma patient who has developed bronchiectasis, ABPA, you give them inhaled steroids because that is the primary treatment for their asthma. Okay, now you have patient with COPD who are having recurrent exacerbations, smoker. In those patients also you may need to give inhaled bronchodilators. Other than these two groups, a small subgroup of bronchiectasis with recurrent exacerbations with multiple inhaled antibiotics courses as well as exacerbations, sometimes a small course of inhaled steroids may be given. But that is a very small subgroup of patients. So primarily only and only for patients who have asthma or COPD and underlying inhaled steroids may be used. If we talk about the oral steroids, it's a clear no for a stable bronchiectasis. For an exacerbation bronchiectasis, you may use a short course of oral steroids if they present with respiratory failure, they present in hypercapnic failure, or they have a lot of bronchospasm, which is difficult to handle just with bronchodilators. But that has to be one doses, two doses. It should not be like 7 days, 10 days steroids. No. So it has to be a very short course of steroid systemic, even for the exacerbation part. So that is the only role of steroids in bronchiectasis.
Perfect, Saurabh. No role for inhaled corticosteroids in bronchiectasis unless it's an underlying asthma or a recurrent exacerbating COPD group E patient with eosinophil levels above 300. Otherwise, no ICS. Sometimes in exacerbations of symptomatic relief, like Saurabh said, maybe. But again, you have to understand the risk and benefit of pneumonia and infections. And as far as oral corticosteroids are concerned, the only time you're going to use oral corticosteroids in bronchiectasis is when it is ABPA. Allergic bronchopulmonary aspergillosis, bronchiectasis, that's the only indication for the use of steroids. And if you have a life-threatening hypoxic exacerbation of bronchiectasis, which is refractory to conventional treatment, probably as a last resort, you would consider as an anti-inflammatory drug in cases of life-threatening bronchiectatic exacerbations. Otherwise, no steroids, no steroids, no steroids. Please remember, antibiotics infection. We are not talking of asthma over here. Okay, it's bronchiectasis where infection is so important. We're really scared of infection in them. Taking that thought forward, Dr. Patnaik, could you tell us how to manage an exacerbation of bronchiectasis?
So first, I would like to give the definition which ERS has given of exacerbation. It is increased cough, sputum production, change in sputum consistency, sputum purulence, dyspnea, exercise intolerance, fatigue, and other complications like hemoptysis. It may be accompanied with chest pain, fever, weight loss, and other complications again like respiratory failure, pneumothorax, lung abscess, etc. So management, obviously, since it is usually this exacerbation is due to infections, IV antibiotics is the mainstay of treatment. An airway clearance technique, which has been elaborated so nicely, that should be used here to remove the excess airway, to help in the airway clearance. And mucoactive drugs like hypertonic saline and acetylcysteine should be given in these patients. And as you already mentioned, corticosteroids, when it is an eosinophilic phenotype, we can consider using corticosteroids. We can also have surgical interventions when there is massive hemoptysis and not responding to treatment, or extensive loss of architecture of the lungs. So, for better management of, and reducing the exacerbations, we can use a surgical interventions.
So Dr. Patnaik has mentioned very well with respect to managing the exacerbation. Exacerbation is nothing but a deviation from baseline symptoms of bronchiectasis. Now you need to risk and stratify these exacerbations, whether these exacerbations are life-threatening or non-life-threatening, and whether they require an emergency visit, an outpatient visit, or an indoor visit. And also you need to understand whether the exacerbations are infective or non-infective exacerbations. If infective exacerbation, which is the most common exacerbation in bronchiectasis, antibiotics need to be initiated upfront and understanding the cause. If it's a viral exacerbation, it's in the influenza season, antibiotics would not be required. If it's a non-influenza season or if it's a non-viral exacerbation, oral antibiotics would be required in managing exacerbations. Hypoxia, not hypoxia, oxygen supplementation, physiotherapy, aggressive airway clearance become very, very important. So whatever conventional treatment is being offered to bronchiectasis, you have to take it a notch higher when you take out exacerbation. Similarly, if the patient is indoor, inhaled bronchodilators, probably in a nebulized form, would be required because of hypoxia and bronchoconstriction. Taking the exacerbation to another level is a rapidly deteriorating patient. Now, Dr. Ramprasad, we often see our bronchiectasis patients deteriorate rapidly. We see the lung capacity is declining progressively. The symptoms are worsening. How do we manage a patient of rapidly progressive bronchiectasis?
Yeah, so first I would confirm the progression by doing a repeat CT, or we would be asking the patient how is the symptoms, whether the mucus production has increased, whether the oxygen saturation or the patient's dyspnea has worsened, or usually check a sputum also, whether the microbiological flora has changed, if there is a new bug that has come, which we are not aware of in the previous cultures. So I would go a step back. So it is a setback for the patient as well as for us. So I would go a step before, which I have missed. Have I missed anything for this patient? Have I treated the airway clearance properly? Has the medications been optimized carefully? Is the patient taking the medications regularly? Or despite of everything and vaccinations and other supportive measures, if the patient is getting worsened, then I would try to escalate my treatment to a next level. So basically, we need to find out what exactly caused the repeated or the rapid progression. Are we dealing with the right diagnosis? If there is a new onset of tuberculosis, or is the NTM, non-tuberculous mycobacteria, or are we dealing with ABPA? First, we need to reassess our diagnosis and confirm whether we are going at the right pace, at the right direction, just like what we do for asthma. Confirm the technique, confirm our diagnosis, and come back to escalation of treatment. So if there is any lacunae which I find out, so whether I have to send it to my physiotherapist, or do I need to change my antibiotics, or is there something I do with my prescribed? I will do that. And once if the patient gets better, or if the patient is reassessed after a particular time, if he goes well, we'll continue that. Or we might have to de-escalate the treatment once he gets better also.
Very well said. It's a very simple algorithm which I follow when we look at bronchiectasis in patients who've been rapidly deteriorating. First and foremost, understand whether you're a specialized center to deal with these patients or no. If you feel you're not a specialized center to deal with rapidly progressive bronchiectasis, refer, because that's in the best interest of the patient. Recognize such a patient, refer such a patient, reassess the entire case history. Like Dr. Ram Prasad very rightly said, when you have a step 5 asthmatic, you rework the case. You start from the basics once again. That's what you need to do. Understand the history, investigate again, repeat sputum, repeat tuberculosis, non-tuberculosis, immunity levels, ABPA, initiate antibiotic therapy, understand the target for the antibiotic therapy, use long-term maintenance therapy with macrolides, inhaled antibiotics, deal with complications such as malnutrition, physiotherapy, pulmonary rehabilitation needs to be focused on. And if it's the patient is in respiratory failure, start the patient on long-term oxygen therapy, rule out type 2 respiratory failure, start the patient on NIV, and finally understand whether this patient would require lung transplant and lung transplant referral. So rapidly progressive and rapidly deteriorating bronchiectasis has a structured algorithm which needs to be followed. And please understand and identify these patients upfront, and whether you are the referral center for this patient or no is something you need to understand in the best interest of the patient. Now, Dr. Ayush, I've got a rapidly deteriorating bronchiectasis patient. When is the right time for lung transplant? Firstly, should bronchiectasis patients be offered lung transplant? And what are the indications for the same?
So thank you, Dr. Avya, for this again interesting and important question. Now, lung transplantation is, considered for advanced bronchiectasis patients with progressive respiratory failure, despite all the maximal medical therapy you have tried. But again, important point to, make sure that early referral is preferred over the late referral. Now, if you look at the HLT guidelines, which has been rapidly endorsed by the ATS and even by the ERS, so they have said that, they have given the two important criteria. The first is when you will refer the patient to a lung transplant center. So they have given a battery of list of parameters. The first is the FEE1, which should be less than, if it is less than 30% of the predicted, or FEE1 less than 40% predicted, plus including the high risk features like the 6-minute walk test distance, getting less than 400. The patient is hypercapnic, PaCO2 greater than 50. The patient is hypoxemic, so resting PaO2 is less than 60, or the patient has requirement of long-term oxygen therapy. There is development of pulmonary hypertension on the echo. Nutritional decline is an important aspect. So progressive weight loss, the BMI going less than 18. There is frequent exacerbations, more than equal to 2 exacerbations requiring IV antibiotics, or making the patients admit to the hospital. Massive hemoptysis, yes, requiring even procedures like bronchial artery embolization, recurrent pneumothorax. So these are the criteria they have been given for the referral. The second is the only when you will list the patient for the lung transplant. So apart from all these FEE1, PaO2, PaCO2, 6-minute walk test, the NIB dependence. So if the patient is either a persistent or a recurrent NIB dependent, there is massive hemoptysis, and the quality of life, important part, that is markedly impaired despite the optimal therapy. So these are the basic two indications. Apart from this, the patient is having chronic multi-drug resistant infections, especially with Pseudomonas or NTM. Although these are not absolute indications, but again, recurrent MDR infections, despite optimal therapy, can maybe make the case or strengthen the case, go for more of the transplant. Now, radiological deterioration also, if you have a diffuse bilateral bronchiectasis, there are severe cystic changes, and of course, we have talked about the progressive respiratory failure and all this failure of the medical therapy. So these are the prime indications or criteria which makes the patients fit for the lung transplant category in bronchiectasis.
Very well summarized, Dr. Pandey. For our practitioners who are new to the concept of bronchiectasis, if you've got a hypoxic bronchiectasis patient or you have a bronchiectasis patient requiring NIV purely for bronchiectasis, and we're not talking of comorbid sleep apnea, when you've got these two situations you're dealing with, that's the time to get a transplant pulmonologist on board and start a discussion. You may not transplant the patient at that point of time, but having that discussion is very important. So very simple, a hypoxic bronchiectasis patient requiring long-term and for that's the time you need to think about lung transplant and get a transplant pulmonologist on board and evaluate and have an honest discussion with this patient. Sejal, the West tells us pulmonary rehabilitation should be continued for 6 months. But what the West doesn't tell us is that their insurance pays only for 6 months. And which is why they say pulmonary rehabilitation is for 6 months. What is the optimum duration of pulmonary rehabilitation in bronchiectasis?
So the optimum duration is minimum 6 to 8 weeks, with at least 2 sessions a week will be supervised and 1 session will be unsupervised at home, or it can be hybrid, that is 1 session tele and 2 session in center. But because the lack of specialized centers providing pulmonary rehabilitation, we can do a lot of tele-rehabilitation. It can increase the reach of pulmonary rehab to patients staying far, who cannot travel alone, does not have a caretaker to bring them to the center. So tele-rehabilitation and home session have proven to be valuable in reaching more number of patients. Minimum duration, as I said, will be 6 to 8 weeks. Maximum duration can be a year, depending on, again, the compliance and the affordability of the patient. Group sessions can be organized and just for the maintenance, not for the initial contact. As a maintenance therapy, group tele sessions play a very vital role in continuation and making sure the adherence part. So that is, I think, because the effect lasts for a year. So if you do it 6 months, the effect will last for maximum 1 year. After that, it wanes off. So continuous contact is important, or they can come back when there is acute exacerbation or any increase in the symptoms. So that's when another point of contact can be obtained. But in between, the patient has to do it on their own. So self-management, patient education is very, very important.
So when we speak of pulmonary rehabilitation, why the West and Europe typically says 6 months is because their insurance companies pay for 6 months. And rehabilitation in developed countries is expensive. In bronchiectasis, when it is a rate reversible disease, the rehabilitation process has to be lifelong. You need to ensure this is inculcated into the patient upfront. Now, when we talk of rehabilitation, there are 2 aspects to it. One is a supervised rehabilitation, supervised rehabilitation. So the first 6 months could be a more aggressive supervised rehabilitation. And once you feel that the patient has achieved some amount of stability and compliance, then the gap between supervised sessions can increase and unsupervised rehabilitation has to go on lifelong. The lung is not going to get healthier. The lung's structural damage is not going to reverse. It's only going to increase with time, and it's our prerogative to ensure that the transition doesn't take place from healthy to unhealthy, which is why rehabilitation has to be a lifelong process. The only difference is that the difference between supervised and unsupervised sessions.
And
Having
even in
spoken,
India, they do get insured after hospitalization. So if the
yes.
patient is admitted for acute exacerbation, it should be prescribed at the time of discharge. So they can start it from the next day itself. And at least 2 months they get. And the maximums up to 6 months, even in India now, they are being offered.
Unfortunately, in India, the insurance is covered after a complication sets in and not to prevent the complication.
Yeah.
But at least something is better than nothing. Thank you for that. Saurabh, we've spoken so much about bronchiectasis. We've spoken about the drugs, management, sputum, XYZ. Tell us something about new exciting drugs which have been launched for bronchiectasis and what the future holds for us in this disease.
So I think one thing which is which I think Dr. Ayush also mentioned as the brensocatib, which is actually the thing which has been in development for almost last decade and now it has been approved. And this is one of the key uh, developments in the treatment of bronchiectasis. So when we talk about the vicious cycle versus vicious vortex, we see that there is an ongoing inflammation. So that ongoing inflammation is generally driven by neutrophils, and then so this drug, neutrophils have a lot of proteases which lead to airway destruction. So this drug is a DPP-4 inhibitor which reduces the serine proteases and then it leads to reduction in airway inflammation. So it has been tried in various trials and now FDA approved for bronchiectasis with recurrent exacerbations. Though, as far as I know, the drug is not yet in India, but I hope it will come soon and it will benefit our eligible patients. So that is the key development which has happened. There is a lot of development on mucolytic therapies, anti-DNase therapies, which will lead to reduction in mucus thickness and airway clearance techniques. There are inhaled antibiotics which have actually been developed over the years. So tobramycin has been there forever. Colistin came, and there are many more coming in for the non-tubercular mycobacterial colonization in bronchiectasis by amikacin and others. So the key development has been on inhaled antibiotics as well as the anti-inflammatory therapies. What we see is that what we have in our armamentarium is not being utilized appropriately. If we can utilize what we have, we would actually be able to help a lot of our patients. I would say 50-70% better than what we are actually doing. So I would say we see a lot of audience here. So this is an important message that you learn and then you practice what you learn is where the future of bronchiectasis lies. So new drugs, new techniques would develop, but they would take time to reach us in India, at least in some parts. So our aim should be what we have available with us in our setting, a small hospital, large hospital. You utilize that best for patient management.
Very well said. Use what you have at your disposal rather than worry about what drugs you don't have. Optimize and correctly use. Brensocatib is one game-changing drug which is there in the West. And I'm very envious of my colleagues in the West using brensocatib because I don't have access to it. Hopefully, it'll come down. A couple of interesting trials which are undergoing. One is with ensifentrine for bronchiectasis as a bronchodilator. It's currently in a phase 2 trial. We also have monoclonal antibodies or biologics which have been approved for asthma being tried in bronchiectasis, typically IL-33 inhibitors for inflammation, that's itepekimab. But again, very exciting, promising data, but long way to go before we achieve any form of approval from agencies. Now, I've exhausted myself, but our audience has not. We've got more than 100 questions which have been asked to us. So I'm going to ensure I answer as many questions in the next 15 minutes. I'm going to go in reverse order. Saurabh, this is for you. Dr. Deep asks us, what is the difference between colonization and chronic infection? A very important and interesting question, I must say.
So colonization has been the old terms which has been used for presence of bacteria in the airways in patients with bronchiectasis. Now what we have understood is that they don't just lie. So it was thought that the bacteria is just lying in the airway is not causing any problem. So that was called colonization. But what we have understood that they don't sit there idle. So they continue to cause a chronic low-grade infection and inflammation and perpetuates exacerbations and airway damage. So now that has actually become a chronic bacterial infection of the airway rather than colonization. And colonization term in bronchiectasis is actually kind of getting removed for presence of bacteria, which is because it is ongoing inflammation associated with presence of bacteria, that is a chronic bacterial infection.
So very simple, colonization means it's confined to the surface. It's not actually adding to the symptomatology burden, but the colonization can turn into an infection at any point of time and cause deterioration and worsening. When we look at chronic infection per se, chronic infection is invading the surrounding tissue and causing symptoms typically associated with infection. So colonization does not have symptoms associated with infection. Chronic infection has symptoms associated. So that's something you need to understand. And the colonization at any point of time can turn into an infection. Sejal, can oscillatory PEP devices replace conventional chest physiotherapy? Dr. Ansett asked us this question.
In certain cases, it can. So traditional physiotherapy like postural drainage is only reserved for those having more than 30 ml secretion in 24 hours. So not all patients are ideal candidate for conventional physiotherapy, which is considered as postural drainage or percussion vibration. Rather, you can club it with active cycle breathing technique or autogenic drainage. As I said, just basic simple breathing retraining helps improve ventilation before using the device, and some 3 to 5 second breath hold while using the device along with forced expiratory technique after using the device can yield much better results. So rather than thinking it as a replacing, it can prove as a better adjunct to the treatment. So
Perfect.
always try for two modalities together rather than relying on one source of airway clearance.
So the physio says it can replace, but please do not go by the physio's mouth. The physio ensures that the physiotherapy sessions are taught to the patient and then gives the PEP device. So please refer the patient to the physiotherapist and let them decide whether the PEP device can replace conventional physiotherapy and whether that patient is only, whether the patient actually requires sessions supervised or no. If the physio feels that no, this patient can do well with the PEP device, let them decide. You don't decide for the physiotherapist. Dr. Ayush, another interesting question from Dr. Deep is, what is the role of lung MRI in bronchiectasis?
Well, if you look at the, HRCT, definitely HRCT remains always the gold standard. But again, if you look at the MRI, it has not been part of the routine workup with respect to the ATS and BTS guidelines, but it can be used as an adjunct tool in selected patients for the monitoring, especially pediatrics, pregnancy, and again, a matter of research. But again, if you look at the gold standard, yes, HRCT, but unlike CT, MRI, there is no ionizing radiation. And so it is particularly helpful in children's pregnancy patients who are requiring more kind of a serial imaging procedures that can be used.
Dr. Deep, sorry, I'm taking this question from Dr. Pandey. Dr. Pandey can't answer this question in 30 seconds. The role of MRI in bronchiectasis will require at least 30 minutes. And you need to remember just a simple point that the dynamic MRI is extremely important assessing lung ventilation when we speak of airway clearance techniques. Typically, mucus impaction scoring done on CT, but the effect in which the mucus gets cleared is very well picked up with a dynamic MRI. So airway obstruction, air trapping, and ventilation of the respiratory tract is excessively seen in the dynamic MRI. Basically, it tells us the physiology of the airways beautifully when we talk of MRI. So yes, exciting data upfront, and probably we would have lung MRI a part of protocol for bronchiectasis maybe in future. Dr. Ramprasad, Dr. Kanak asks us how often sputum in stable bronchiectasis patients.
So initially we used to get a sputum investigation probably during an exacerbation, and most of the times the flora doesn't change much, especially in a colonizer. We repeatedly get a pseudomonas or a Klebsiella, or depending on the local flora, we get an antibiogram for the particular patient. So we usually routinely don't repeat a sputum investigation unless the patient gets an increase of sputum production, increase of volume, or increase of purulence. So if the patient is worsening, so as we discussed in rapidly progressing bronchiectasis, if the patient is having worsening of symptoms, or is there is a more amount of accumulation of mucus, if the patient is unable to clear the mucus secretions as good as he used to do before, if the patient is not doing well, you might have to repeat a sputum, or radiologically also you might repeat a X-ray or a CT chest. So that is where I actually repeat a sputum, not a predefined sputum interval or anything of that sort. we might have to repeat a PFT or a CT in particular intervals if the patient requires. So the same applies for the sputum culture also, as far as the treatment guidelines go.
So excellent, very well said. Doing routine sputum examination in stable bronchiectasis patients is not required unless the color and the quantity of sputum has changed. If the patient is still having no worsening of symptoms perceived by the patient, but the color of sputum has changed, probably this patient is moving from colonization to a slow chronic infection or probably an impending exacerbation. So that's the only time you must repeat a sputum evaluation in a stable bronchiectasis patient. And our bronchiectasis patients are very smart. They've all got jars. They collect the different colored sputums, green, yellow, blue, thanks to Pseudomonas and other organisms. And they themselves come and tell us that, listen, doc, the color has changed. It was light yellow or white. Now it's turning green. Do we need to look at anything? We're stable. But that's the time you would do a repeat sputum analysis in a stable patient. Or sometimes when there's weight loss, unexplained weight loss without any symptoms, that's the time non-tubercular mycobacteria or tuberculosis needs to be suspected in bronchiectasis patients. Jyoti madam, why do some patients with extensive radiological bronchiectasis have limited disease symptoms? The point which we raised about the Asian population having discrepancies in the symptom and disease severity.
We have seen that in many cases of post-TB bronchiectasis, usually the symptoms don't match with the extent of the destruction that we see in an X-ray. So in those cases, generally, we see that symptoms are not matching. And sometimes those cases where like ABPA or something like that, where the symptoms are much more than what you're seeing on a X-ray. That has been noted in these cases.
And also, our Indian population is used to living with symptoms and underplaying rather than coming to the doctor and expressing their symptoms. And probably they're used to this is a way of life, and having access to general practitioners more easily and over the counter medication easily tends to underplay their symptoms and disease severity. So the slow ongoing structural damage keeps happening. And the only time they come and present to us upfront is in the ICU or a hypoxic or a hypercapnic respiratory failure. Saurabh, we've got another interesting question. Why does Pseudomonas impact bronchiectasis and why only Pseudomonas is so important? This is asked by Dr. Khushi.
So, I mean, Pseudomonas, if you talk about how Pseudomonas actually grows, is it has classically been seen that Pseudomonas grows in wet environments. Okay,
Yeah.
so if you see in ICU, you have humidifiers, you have wet tubes, everywhere where there is wet, the Pseudomonas grows. So that's why for the airways which are wet and filled with mucus, Pseudomonas is something which grows very rapidly in those airways. Now, how does Pseudomonas worsen bronchiectasis? Because Pseudomonas leads to a lot of worsening of the inflammation, air epithelial damage, and mucus hypersecretion. So that's why, and epidemiologically, if you see classically since the time bronchiectasis has been described, Pseudomonas, because of the presence of high mucus, has been the key organism for driver of inflammation in bronchiectasis. That is why even today, if you have Pseudomonas, you have bad disease. If you have Klebsiella, even if you have other MDR organisms, except I would say the Burkholderia, the prognosis is worst with Pseudomonas because of its ubiquitous nature of growing in wet environment. And if you have wet airways, you would have Pseudomonas today or tomorrow. That's for sure. So that is why it is important, because if you eradicate that, your airway inflammation goes down significantly as compared to if you do not eradicate a Pseudomonas.
So basically what Pseudomonas does is, it is a session back in microbiology, it results in a biofilm formation. So what the biofilm does, it makes an armor and lets the bacteria multiply. And in turn, this bacteria causes paralysis of the cilia, which prevents mucociliary clearance. So you've got bacteria, which causes a biofilm formation, where the bacteria multiplies and eventually it causes paralysis of the cilia, which causes progression of the disease by impairing mucociliary clearance. So essentially, if you ask me, what happens is Pseudomonas mimics a CFTR or a cystic fibrosis kind of a picture, but in a mild and a chronic form. So it paralyzes the cilia completely, and the cilia doesn't have any work and can't expectorate. Sejal, An interesting question. What are the contraindications of physiotherapy?
So as far as I know, the latest guidelines also says that there are no contraindication. The only thing to be taken care of is when there is active hemoptysis. So it can be halted for some time, but as soon as the active bleeding stops, you can resume airway clearance. There are no contraindication for physiotherapy.
Active
In head low
hemoptysis,
position, if
probably
you
when there's active hemoptysis, that's the time you would want to understand the reason for hemoptysis before you continue with physiotherapy sessions. Probably even the physios come and tell us that the patient has started to have hemoptysis, you'd like to investigate or evaluate. I guess that's a contraindication, right?
so for the time being, yes.
Yes.
Once
Yes.
the active bleeding stops, you can actually resume as soon as possible.
Correct. Now, what I need to understand, okay, Dr. Ayush, can you tell us the indications for bronchoscopy in patients with bronchiectasis? Dr. Kapil asked us this question. Do we have Ayush? Okay, yes, we have.
Hello. Yes, yes. So I think, Dr. Avya, you have already answered to this indication of bronchoscopy. I think the time we were discussing, and respect, it is not routinely indicated for all patients, and it is reserved for selective therapeutic and diagnostics. So if the patient, again, if the patient is having maybe a localized bronchiectasis, which is the strong indications for bronchoscopy, and again, when you have to exclude an endobronchial obstruction, if there is a carcinoma, there is a foreign body obstruction, there is post-tubercular bronchial stricture, or a mucus plug that is causing obstruction. So bronchiectasis confined to one lobe or a segment on the HRCT. When you have a suspected endobronchial lesion that is confirmed on the imaging, suspected NTM disease, so sputum cannot be obtained, and still the repeated sputum cultures are negative despite having a strong clinical perception. There is a nodular bronchiectasis with trine bud appearance. So bronchiectasis improve the microbiological yield. Suspected tuberculosis, yes, sputum smear is negative, but still the clinical suspicion is high. So BAL and bronchoscopy improve the diagnosis. Another one indication is, yes, persistent hemoptysis. When still you are not able to find out the cause, the localization of the bleed is still you need to confirm. And of course, you are suspecting an endobronchial malignancy, suspecting a fungal disease, or especially in immunocompromised patients when there is opportunistic bacterial infection or CMV fungal infection. So these are the probable indications of bronchoscopy in bronchiectasis patients.
So I would say when the sputum evaluated is not explaining the symptoms or the radiological findings, and when you're
Yes.
suspecting a mixed infection or another infection or an alternate diagnosis, that's the time bronchiectasis would require a bronchoscopy. And yes, active hemoptysis, we need to find out why this patient is coughing out blood. Now, Dr. Vikas is asking an interesting question. Why should we do a sputum test before starting macrolides for non-tubercular mycobacteria? Dr. Ramprasad, would you want to take this question?
Yes, sir. So macrolides, the azithromycin becomes the one of the essential drugs and the core drugs for the non-tuberculous mycobacterium. So as and when the macrolide resistance is already increasing per se because of rampant and inadvertent use of antibiotics. So we are giving it for a longer time, usually for around 6 to 12 months. That's what the guidelines have been given. So once we are considering for a long time, might as well we need to exclude a disease. If at all we need a therapeutic aspect to be given for a non-tuberculous mycobacterium, we need to check it first, or even during the course of the disease also, the patient might have a repeated exacerbations which might want us to evaluate for NTM. So if the patient has a disease of NTM, we might as well treat it first rather than going into the preventive aspect of going into a long-term macrolide. So that would make sense rather than excluding it upfront.
Yes, because if you are having a non-tubercular mycobacteria, you're potentially treating with monotherapy and causing resistance with the drug in future, which is why sputum evaluation should always be done. The last question of the day to Jyoti madam is, has the vicious vortex understanding and the new definition of vicious vortex changed our concept of bronchiectasis? This is asked by Dr. Jay from Surat.
Yes, it has to some extent changed the, it's brought in new concept to the treatment, the diagnosis and the management part of the bronchiectasis. This has been already discussed, I think. The new vortex has been already discussed.
What essentially it tells us that infection, impaired mucociliary clearance, and structural damage were given excessive and importance, which is true. But inflammation becomes an equally important part and corner when we look at bronchiectasis, and that's why understanding and treating inflammation and the causes of inflammation becomes so very important. So yes, to a certain aspect, to a certain way, it has changed the way we treat bronchiectasis. We always understood that inflammation was important. Adding it from the cycle to the vortex is in a way of treating the bronchiectasis. So yes, I've had a fantastic discussion with all my panelists and speaker with respect to brainstorming questions of bronchiectasis. We've tried to answer as many questions as possible. We have still loads of questions which are unanswered, and I encourage the audience to reach out to any of the faculty members, and they would be happy to answer questions pertaining to disease diagnosis, management, and follow-up, and for physiotherapy related questions to Dr. Sejal Bheda. Before we end today's webinar, I'd like one final take-home message from all our panelists, starting from Dr. Saurabh.
So I think one key message from my discussion is that do not miss bronchiectasis. That is first. And if you have CT bronchiectasis, do not label idiopathic. So that I see a lot of idiopathic bronchiectasis coming to us, and people have not really looked for etiology. So look at the radiology carefully. Look for clues on a CT scan, which will give you a diagnosis. Look for other investigations. Try to get a workup done primarily for etiology and then manage. Most of the times we provide a blanket therapy to bronchiectasis patient without actually finding the cause of bronchiectasis. So that's etiological evaluation is very important for a good long-term outcome.
Dr. Ayush.
So, Doctor, bronchiectasis has basically evolved. We have seen evolution from the basic science to more kind of translational research, clinical management, and now it is about the patient-centered care and, of course, the future innovations which are still there. So, definitely, when we talk about the bronchiectasis per se, specifically like lung transplantation, so identify early, refer early if it is being needed, and rather than going or becoming late for the procedure. So refer early rather than waiting late. Optimize the patients, go for the patient-centered care, and of course, more kind of the clinical management per se procedure is being needed.
Dr. Ram Prasad.
So as far as the long-term macrolides, it is not like your regular therapy. It is usually given for your non-responders, the patients who are having exacerbations more than 3 per year, as per the ERS statement. And for Indian scenario, the caution has to be exercised because we have more amount of NTM macrobacteria. So if at all you are trying to prescribe, I would might as well rule out NTM in the first place. And for long-term macrolides, you have to get a PTA, as you have already mentioned, pure tone audiometry to rule out hearing loss, and also ECG to rule out any QT prolongations also. So that's what my message would be.
Dr. Patnaik.
Bronchiectasis has been a very important disease for us in India, as you all know, as pulmonologists. And it has every student, MBBS student, if he gets a final year case of bronchiectasis, I'm sure he is very excited. It is not at all an orphan disease in our country, and we are well aware of the treatment. And we are excited about the newer treatments that are coming up that would give a better life and better quality of life to those patients who are suffering from bronchitis.
Sejal.
Just a last sentence. Refer every single patient to chest physiotherapist for better management and better compliance and adherence to the treatment, because we spend more time with the patient. We spend a lot of time in patient education. So they understand the importance of pharmacological and non-pharmacological modalities available, and then they do adhere to the treatment.
Thank you. And finally, from my side, in respiratory medicine, pharmacotherapy is first and non-pharmacotherapy options come later. But when we talk of bronchiectasis, non-pharmacological therapy has to be offered to each and every patient. right from pulmonary rehabilitation, airway clearance techniques, devices, physiotherapy, nutrition because of malnutrition, CO2, adult immunization, and most importantly, counseling and education. Non-pharmacotherapy is equally and probably more important in select cases of bronchiectasis, and that should not be neglected because it significantly impacts the quality of life and improves both morbidity and mortality. On that note, I'd like to thank all our panelists and speaker, Dr. Saurabh Mittal, Dr. Ayush Pandey, Dr. Ram Prasad, Dr. Jyoti Madam, and Sejal for enlightening us and having an extensive discussion on bronchiectasis. I certainly learned a lot from today's topic and webinar. On that note, thank you everybody. Good night. And I really thank the ICS for giving me this opportunity to conduct this webinar. And thank you for the streaming partners for all the tech and logistics support. Thank you. Good night, everybody. Thank
Good
you.
night.
Thank
Thank
you.
you. Good night. Good night.
Thank you all.
Thank you.